and large, the most common diagnosis that I see is osteoarthritis, which is the wearing away of the cartilage inside your knee. Now, the knee is made up of your thigh bone, your shin bone, and your kneecap. And you have cartilage, like the white stuff at the end of chicken bones, that protects the bones from touching each other. Bones have nerve endings, and so this cartilage protects that, and it allows things to glide smoothly. Osteoarthritis is when that cartilage wears away, and those nerve endings are exposed, and because you're bearing weight through this joint, you're going to get pain because you're putting pressure right on there. And then also, everything that lives in there, like your medial meniscus, your lateral meniscus, it's going to be torn, right? It's sandwiched between your thigh bone and shin bone, and so that's what the disease process is. So a total knee replacement, what we do is we shave off the cartilage, and we cap your thigh bone and we cap your shin bone with metal, and we put a piece of plastic in between. And sometimes we'll even have to put a piece of plastic underneath your kneecap so that everything is riding nice and smooth, and the nerves themselves aren't touching. An example of a total knee replacement is seen here. And in terms of the resurfacing, I use a robot to do the surgery, and we will actually shave off, based on your anatomy, the exact part, and then we'll cap it with metal here. Similarly, for your shin part, we will shave off any cartilage that you have there, and then we'll cap it with metal down here, and then we'll place a piece of plastic in between. So now you have metal, and plastic, and so those nerves aren't going to be touching.
Okay. After the surgery, what happens after the surgery?
So after a total knee replacement or a partial knee replacement, patients are in the recovery room. By the time they're waking up, the spinal anesthetic that we utilized to numb their legs should be wearing off. You'll be able to move your toes. And once you're more awake, you work with physical therapy almost right away. They'll review home exercises with you, and my patients typically go home the same day. And we're able to do that because of the help of our anesthesia colleagues and multimodal pain regimen. And to be honest, it's a lot of education. Now, once you're home, I want you to take it easy for the first 2 weeks. Follow the directions that we talk about. Ice this leg 20 minutes on, 20 minutes off as much as possible, and really focus on controlling the swelling. After 2 weeks, I'll see you in the office. We'll take a look at the incision, make sure everything looks great, and then you either start physical therapy or continue with your home exercise regimen. And it varies from a patient per patient basis. At about the 4 to 6 week mark, you're walking around walking around better. At about the 8 to 10 week mark, you're about 80% of the way there, but the remaining 20% does come back slower. I typically say you're going to show improvements upwards of a year. Now, the majority of the improvement is within the first 3 months. You might have some swelling, some stiffness still at month 4 or 5, but you will be in a better state than you were beforehand, and so it's just something that we have to give time. But again, this is on average. Some patients do significantly better, and they recover a lot faster, and we'll navigate that together.
What should I expect about pain? Like, what kind of pain am I going to experience after this?
So post-operative pain after a total knee replacement is something that is largely talked about in the orthopedic community, amongst the patients. I'm sure you've had a neighbor or a family member or a friend who's had a knee replacement. And it is a quite painful procedure, and we've been focusing on seeing how best to control pain postoperatively so that patients can do their exercises, control the swelling, get on their feet, and really just make it as much of a pleasant experience as possible. Now, with all that said, it is an arduous recovery for the first 1 to 2 weeks. I don't try to sugarcoat it too much, but I do have multimodal pain regimen, a lot of education, a lot of different modalities that we do to help mitigate that immediate pain. There is some swelling that occurs again at the 1 week mark. This is all something that we talk about at length. But really having the multimodal pain regimen of Tylenol, an anti-inflammatory, potentially a steroid, and some other stronger medications, as well as other medications such as a stool softener, things to really prepare you for anything that might happen in the post-operative setting. All of this is essential in terms of recovery. And people handle pain differently, but for for the majority of patients, this rapid recovery protocol has been very, very successful. And it's allowed us to get patients home, just hours after their procedure. And by the time I see them in, 10 to 14 days from surgery, some of them are, not using a walker, or some are using a cane. And so we've had great success with our protocol.
Yeah, so on that, what kind of assistive device will I need?
Yeah, so and patients will ask about an assistive device, whether it's a rolling walker or a cane. I've had some patients ask about wheelchairs, right? And really it's my job to educate my patients that after a knee replacement, our goal is to get you on your feet and walking. And so I will have you utilize a rolling walker the day of surgery, and likely for about the first 2 weeks, just because I want you to be stable and really gain confidence with your knee. Pain and swelling is normal, it's expected, and so a rolling walker really gives you that confidence. You can use a rolling walker up to 4 to 6 weeks, but a lot of patients will slowly transition after the 2 week mark. You transition to a cane and then ultimately back to your normal baseline and hopefully off of an assistive device altogether.
What should my expectation be about when I can return to my normal activities, especially like driving?
After a total knee replacement, a lot of patients will ask, when can I return to drive? And so it is a personal decision, but as long as you're not on narcotic pain medications and your pain is well controlled, and you feel comfortable behind the wheel, then you're cleared to drive, or you're okay to drive. Typically for my patients, I say for your right side is typically about 3 weeks, for your left side is about 2 weeks, but it does vary. I think the big one is assessing the patient's comfort level. I can't clear you to drive, but I can kind of go through, what the recommendations would be, and just assess really how comfortable you are behind the wheel. And patients are very good at kind of self analyzing and tailoring that, and seeing if they're good to drive. But for the most part, it's 3 weeks for the right side, 2 weeks for the left, and yeah.
What about other restrictions? Like, are there things that I can't do for a period of time afterwards?
So after a total knee replacement, a big thing that I counsel my patients on is to try to take it slower. Right, patients, gone are the days of aggressive physical therapy in the immediate postoperative period. Right, so I have patients who are very motivated, but they can end up doing too much. So I think the biggest thing is kind of dialing that back, right? Walk to and from your bathroom, to and from your kitchen, and then really just try to take it easy. Do your home exercises that the physical therapist reviews with you, and ice your knee. Try to control the swelling. I think if you really focus on controlling the swelling instead of doing laps around your apartment or laps around your house, that's really what's going to benefit you. So a big thing in terms of the restrictions are my quote unquote take it easy for the first 2 weeks, and then really with the technology that we have nowadays, a lot of the components that I'm utilizing are called press fit components. So we're not using cement, and so you do have to give it time for the bone to grow in and grab these components. So I try to go, I want my patients to shy away and refrain from any high impact activities, right? Jumping, basketball, no jumping out of planes, nothing like that. Which goes without saying, but it's something that I just want to counsel my patients. No high impact activities, and just slow down a little bit.
Okay. What are the risks?
So patients will ask, what are the risks after a total knee replacement, or what are the risks of a total knee replacement? So whenever you make a skin incision, there's always a risk of an infection, right? And unfortunately, in the case of a total knee replacement, it is one of the more dire or serious complications to have, because it's a lot of metal, and we cannot just give you antibiotics. That typically is treated with another surgery. So one of the risks for a total knee replacement is an infection, and it's largely based on the patient's comorbidities, their history, their surgical history, past medical history, and it's something that we have to optimize them for. Another risk is a risk of wound complications, right? We do a plastic surgery closure, and we monitor the incision throughout. Another risk is a risk of a blood clot, right? Everything is, you might develop pooling and swelling of your lower extremity, and it does put you at a risk of a blood clot. And so we will place you on a blood thinner after surgery, and that's dependent on your medical risk profile, and whether, what degree of a blood thinner to give you. There are some risks, such as a fracture or stiffness, that are somewhat out of our control, but whatever, we'll have to, we'll take care of you, whatever those risks are, or whatever the complications are.
How long will the new knee last?
So patients ask, how long will my total knee replacement last? So the good news is, with the technology that we have nowadays in terms of the implants themselves, these knee replacements are lasting 25 to 30 years, and that's the latest data that we have. They may last longer. Historically, the pieces of plastic that are in the knee replacement would wear out. Nowadays, we don't see that as often. We also use Of course, it depends on the patient's bone quality, but sometimes we'll use press fit components or cementless components where the metal themselves or the metal itself has nooks and crannies that the bone will actually grow into, right? But of course, we could also use cement, right? But regardless of what fixation we use, these knee replacements have been lasting approximately 30 years. So patients will always ask that, and it's something that I'm happy to let them know. These things will last a while.
Yeah. What else? What do you got?
Knee replacements. Oh, subvastus, the muscle sparing,
Okay.
and then the robotic. So patients are asking about a muscle sparing total knee replacement. And I was one of the early adopters and I believe one of the few to do a quadricep sparing or muscle sparing total knee replacement. It is when instead of going through, which is the tried and true.
Say that last line again. Our audio just cut out.
Oh, no worries. So patients will ask about a muscle sparing or a quadricep sparing total knee replacement. Now, I was one of the first to bring this approach into the area. And so the traditional way of going through the quadriceps tendon, there's nothing wrong with that. It's the way it's always been done. Can sometimes lead to more inflammation in the first 4 to 6 weeks, right? But the outcomes are great. But what we started doing now is going underneath the quadriceps muscle. And so when we go underneath the quadriceps muscle, I actually move the whole muscle to the side and do the whole knee replacement without having to cut through one of the largest muscles in your knee. Now, I do largely base this off of the patient's anatomy, as if I do this for all comers, I may have to release a little bit more. And so I have to find a balance between soft tissue dissection and really trying to decrease the amount of inflammation inside the patient's knee. Historically, this approach can lead to putting the components or the actual total knee replacement in the incorrect position, because it is harder technically for us to see what we're doing. And sometimes you position the components in the wrong position, right? And so it makes sense to go back to the tried and true. However, I pair my muscle sparing or my quadricep sparing approach with the use of a robot. And so the robot allows me to not only cut to 0.5 millimeter in accuracy or 0.5 degree in accuracy, but it guides me in terms of placing the components where I want them to be placed. So I'm able to pair the muscle sparing approach with the the robotic total knee replacement, and I have seen exceptional results in the immediate 4 to 6 weeks. But not everyone is eligible for it, and it's something that I counsel my patients on. Regardless of whatever approach we use, there's a reason why I do certain things. And if patients want to know more, we can absolutely talk more about kind of what their options are.
Yeah, tell me about the robotic and what's entailed in that, and then why you would be a candidate for that versus not.
So it's a great time in orthopedics right now in terms of the enabling technologies. Patients have come to me asking about a robotic total knee replacement. Now, for all of my primary total knee replacements, I do utilize robotic assistance. And it's very important for me to say assistance because the robot is a tool. So I would say the best thing about the robot is that it allows the surgeon to put the components exactly where they want, right? It increases our level of accuracy. For me, all in all, I think that means less tissue dissection, less inflammation, and it's really tailored towards the patient's anatomy. So one component is we get a CAT scan of your knee, and so we're replicating your bony anatomy. But the knee is more than just the bony anatomy. In my hands, I'm able to stress the knee in certain ways and really get a feel for what the person's knee is or what it wants to do. And so I can adjust the plan of the robot, right? So I get the knee to feel or do what I want it to do, right? And over time, I've gained my touch. So it's both, it's science in terms of the robot, and it's art in terms of kind of the feel for it. But that's what I've developed. And so it's great because it's increased accuracy, less dissection, tailored towards the patient. It really, really is personalized. It's an outstanding technology. But again, it is a tool. And so not all robotic surgeons are alike. And then lastly, one of the big things, you say robot and people think it's a really mini incision. A total knee replacement, you do have to make a larger incision. It's not, a general surgery or like a laparoscopic procedure. You do have to make a bigger incision, but the benefits of the robot, it's outstanding. It allows me to really tailor and customize and personalize the surgery for the patient.
Fantastic. Okay.
Awesome.
What else?
What else?
Are you using genetics?
No, not yet. I mean, it's like tough to get
Yeah.
down here. I guess like there was one rep,
Yeah.
and then they quit or something. I don't know. It was like a couple months ago.
Okay.
There was a guy up by Jupiter that was using it, and so I was asking him about it.
Do you guys do the smart knee? Do you do the?
I don't. That's like
That's mostly Zimmer.
yeah, Zimmer, yeah.
He did Striker.
Yep. I'll do Zimmer for revisions.
Oh, yeah.
Yeah, sometimes. The orthogrid is the big deal. The subvastus, the robot. What are some other stuff that people ask about? The swelling, the pain. I think that's it.
Yeah.
Yeah, that's good. It's a lot.
Awesome.
Yeah, you did great. It's almost like you do it every day.
I do. Yeah.
Just not in front of a camera.
No. I was like, it is exactly what I tell patients. So it's like, I was like, oh, is it too like casual? But then at the same time, it's like, it'll be fine.
Yeah,
Like,
that's perfect because that's who's going to be seeing it.
Right. Yeah. And then I guess this whole thing came about with with Gemini. So Google is using Gemini, which is like AI, to kind of answer the questions and kind of lead you to the right result. And so it's going off of YouTube videos. Mm-hmm. And so it's just like, if you, they do.
Oh, okay.
Yeah. So I was looking at one of the competitors, and his YouTube page is literally just a testimonial, but it's just like stock images, and it's like the printed testimonial, just the text. But he's got 100 of these videos, right? Yeah. And they all say like total knee, Mako robotic, or like robotic assisted, Avino, yeah. So if you look at Avino's YouTube page, it's all, it's all these like weird testimonials. And so I was like, oh, well, I like these testimonials much better. The production is so much better. And then in terms of his video, it's very robotic. He's talking about, and he marketed a Palm Beach hip, which is like the bikini. Remember, I was like, the bikini incision. And anyway, so he was marketing a Palm Beach hip, but he's like very robotic. So I'm just trying not to be like that.
Yeah.
There is something that we could talk about, kind of hospital versus ASC. Yeah. Because I am going to be working at an ASC a couple months. Mm-hmm. Yeah.
Okay.
Right.
Yeah. Tell me that. You just want to talk about the comparison of like why. Because you still do hospital?
Yeah, but I'll still do it at outpatient. I guess it'll be a short little thing, but so patients will ask, where am I getting the surgery? And right now, total hip replacements and total knee replacements are largely being done in the outpatient setting. And so ambulatory surgery centers are a more, kind of not refined, but they have a different type level of care where it is outpatient. So you come in, you have the procedure done, and because of the education that we do beforehand, you're actually able to work with physical therapy and go home the same day. Now, in the hospital, I am also doing outpatient surgery in the hospital setting, and that's a little bit more geared towards patients who have a higher risk profile. And it is always nice to have that quote unquote safety net of, if anything were to happen, you do have that safety net there. I don't know. I don't know if I like that, but
Yeah.
yeah.
Yeah, I would
Maybe just say outpatient.
Yeah, I would just stick to, if you're gonna say that,
Yeah.
stick to like some higher risks,
Yeah.
comorbidities, whatever.
Yeah.
May make you fit for the hospital.
Yeah, let's do that. So total hip replacements and total knee replacements are largely being done in the outpatient setting, and so the majority, or pretty much 100% of my patients, right, the plan is to go home the same day. Patients do better when they're home, and so my job is to get you the right resources, whether that's education and just everything that you need, right, to go home, and to have a successful recovery. Now I am doing this in the outpatient setting. And so there are ambulatory surgery centers where you come in, you have your hip or your knee replacement done, you work with physical therapy, you have all the education there, and then you get to go home and recover at home. Now there are,
Lost our light.
Battery?
Yeah, I'm sure it's battery. One second. Either that or it just overheated. Okay, here it comes. I think. We good?
Yeah.
Is it on?
yeah.
Okay, sorry about that. Okay,
All right,
continue.
let's go. Did I start from the top from that
I
top?
meant to start from the top.
Okay. Now, there are some patients that have a higher comorbidity, medical risk profile, more comorbidities. And even in those patients, the plan is for outpatient surgery, but sometimes they're better suited to be done in the hospital setting. But even in the hospital, I've had a great relationship with the hospitals that I'm partnered with, and we have my particular protocols where everyone is on board. It's a paradigm shift in terms of total hips and total knees. Right. In the past, patients were staying overnight for 3 days, even a week, even, right. But nowadays, because of the anesthesia, because of the education, because of the implants, the technology, the approach, it's multifactorial. But we're able to get patients home, and nothing beats recovering in the comfort of your own home, with a family member, friend, and patients are doing great. And so whether it's done in the hospital setting or an ambulatory surgery center, our plan is to get you home.
Fantastic.
Cool. Love that.
Okay. We will cut these up.
Yeah.
For the FAQs.
Yeah.
And then we'll create transcripts of them, so
Mm-hmm.
we have that on the website and on the YouTube videos.
Cool.
And you get.
Awesome. The transcript is just like closed captioning, or it's like on the actual.
So it'll be closed captioning on the YouTube videos.
Yeah.
If somebody turns that on. But
Yeah.
in the description, we'll put the transcript.
Nice.
So it's all SEO'd.
Yeah. Perfect.
Yeah.
Perfect. Awesome. And then is it like everything gets uploaded all at once, or is it just like a slow rollout, or what's
This will be all at once.
Awesome.
The way we want to do it, with like it being an FAQ. Basically.
Uh-huh.
Yeah.
Well, I love that.
We can use some like of the clip videos like for social media posts for like
Yeah.
whether it be like arthritis month or something like
Yeah.
that. We can
Mhm.
always do like things like that too. Like
Yeah.
sporadically.
Yeah.
But otherwise just throw it all onto YouTube.
Throw it all out. Yeah. And then how's it work with like ads? Like, or is it? Well, I guess that's different because there's no like video ads, right? It's like they're like posts.
Yeah, depending on